So, now we will talk about menopause. What is menopause? It's defined as 12 months of amenorrhea, so no menses, average age of 51 years, derived from Greek words men, month, and pauses, cessation. It's a period when the primary ovarian function ends. It marks the permanent end of fertility. It may happen for iatrogenic causes such as after chemotherapy or surgery. It has a familiarity in premature ovarian failure if there is a positive familiarity for precocious menopause. What is perimenopause? Perimenopause is the transition phase because menopause is not sudden. It's a gradual phenomenon. During this phase, we can have some symptoms that will anticipate the later arrival of menopause. Change from normal ovulatory cycles to complete cessation of menses, marked by menstrual irregularity, may begin years prior to menopause, and we have an onset of menopausal symptoms. The reproductive cycle. How is the reproductive cycle? During the first part of the cycle, under the influence of estrogen, there is the increase of endometrium and ovulation, also due to surge of LH. In the second part of the cycle, there is the influence of progesterone. Progesterone maintains the trophism of the endometrium in order to be ready in case of pregnancy. In pathologic conditions, there can be anovulatory cycles, no ovulation and no luteal phase. Estrogen leads to increase in endometrium size. Thus, anovulatory cycles can lead to endometrial hyperplasia under the continuous influence of estrogen. But estrogen is not capable of keeping a good trophism, therefore there will be bleeding. But this pattern may be found physiologically also in perimenopausal period. Thus, a physician should investigate the cause of anovulatory cycles. So, anovulatory cycles should be investigated. And during the first part of the cycle, there is, under the influence of estrogen, there is increase of endometrium and ovulation. The second part, progesterone. So, menopause. 85% of women will experience some symptoms, such as vasomotor, hot flashes, night sweats, formication, and scrolling. Then urogenital, like vaginal dryness, atrophic vaginitis, dyspareunia, local microtrauma, and incontinence, and physical changes, decreased fitness and flexibility, changes in distribution of body fat, changes in sleep patterns. So we have vasomotor, urogenital, and physical changes. Perimenopausal bleeding. How is it? We have anovulatory cycles can lead to endometrial hyperplasia. Can have prolonged, heavy, or frequent bleeding should be an alarm. Options to control bleeding and protecting endometrium against hyperplasia are low-dose birth control pills, cyclic progesterone, Mirena intrauterine device. It releases progesterone. And ablation of endometrium may also be used to control bleeding. We then have changes in hormonal pattern. Inhibin levels fall, and inhibin is produced by granulosa cells. Decrease may derive from increasing number of follicles or reduced quality capacity of the aging follicles. And also serum FSH levels rise, slight increase in estradiol levels, cycle variability increases because of hormone levels fluctuate and FSH and estradiol may return to premenopausal ranges. After menopause, ovaries no longer secrete estradiol, but they continue to produce androgens. So no longer estradiol, but still androgens, under continuous stimulation of LH. Elevated levels of FSH and LH, evidence of ovarian failure, which is the definitive diagnosis of menopause. So, the hormonal patterns we have are inhibin levels fall, serum LH and FSH levels rise, slight increase in estradiol levels, cycle variability increases because the hormone levels fluctuate, and after menopause, ovaries no longer secrete estradiol, but it continues to produce androgens. Symptoms, more in detail. What are the symptoms? We have a loss of elasticity of skin and supporting tissues, so worsening prolapse, loss of breast tissue, wrinkling of skin. We have an emotional and physiological changes, anxiety or depression, insomnia, lack of concentration, poor memory. We have effects on bone, osteopenia, osteoporosis. We have other like change of body shape, loss of libido, change in body hair distribution. We then have hot flashes. We have vaginal dryness. We have mood changes. We have bladder irritability, urgency. We have changes in balance. We have a decreased interest in sex, possibly decreased response to sexual stimulation. The symptoms in menopause greatly depend on a series of factors. Amount and rate of estrogen depletion. The inherited and acquired capability of adjusting to changes occur associated with the process of aging. Psychological impact of aging and the individual's reaction to the emotional implications of such change. The age of menopause varies greatly among different women and also greatly depends on possible pathologies. Early menopause is associated to a series of risk factors. You have an early transition due to smoking, nulliparity, high altitude. Tubal ligation has no effect on timing. Family history is the most important factor. So, the early menopause risk factors are smoking, nulliparity, high altitude, and family history, which is the most important factor. Tubal ligation has no effect. Physical changes in body caused by menopause are weight gain, decrease in bone mineral density leading to osteoporosis, hair changes, thinning of hair on scalp, appearance of hairs on face, loss of skin collagen, and progressive drier skin. Sleep disturbances caused by menopause are sleep studies suggest nocturnal hot flashes more common during the first 4 hours of sleep. REM in subsequent 4 hours suppresses hot flashes, arousal, and awakenings. Sleep is affected by anxiety and depression symptoms. Primary sleep disorders are very common, like sleep apnea, restless leg syndromes, or both. So, in menopause, we have many sleep disturbances. Nocturnal hot flashes in the first 4 hours of sleep, and REM in subsequent 4 hours suppresses hot flashes, arousal, and awakenings. We have then vasomotor symptoms, which are the most characteristics and affect the quality of life because they influence sleeping patterns and can be related to mood disturbances. They most often begin in perimenopause. We have a sudden onset reddening of the skin, head, neck, chest, feeling of intense body heat, and profuse perspiration. We have variable intervals from minutes to hours. They tend to be more frequent and severe at night. They generally stop spontaneously after a few years, but they may persist for many years, and 12–15% of women stop having such symptoms in their 60s, while 9% report cessation after age of 70s. So, tend to be more frequent at night and variable intervals, sudden onset reddening of skin, feeling of intense body heat. Hormone replacement therapy. So, as a general rule, keep in mind that when administering hormone replacement therapy to women in perimenopausal age, anti-contraceptive pills should be administered concomitantly to avoid unwanted pregnancies. This is due to the fact that in perimenopause there may be ovulatory cycles and therefore, even if very rare, a small risk persists. Postmenopausal hormone regimens, hormone replacement therapy, do not suppress ovulation. The oral contraceptive pill that contain 20 micrograms of estrogen provide effective contraception. Even lowest dose of oral contraceptive pills provides 4 times higher estrogen dose compared to standard hormone replacement therapy. So, estrogen therapy use declined in the mid-70s due to the demonstration of a link between estrogen therapy and the development of endometrial cancer. When estrogen was then coupled to progesterone in the 80s, it was found to be no longer associated to neoplasias, but actually had a more protective effect. Now indications have greatly expanded prevention of all diseases related to aging. So, what are the estrogen benefits? Oral estrogen causes a decrease in LDL levels, lipoproteins, glucose, insulin, homocysteine levels, and oxidation of LDL. It causes an increase in HDL levels and also cause an increase in triglycerides, coagulation factors, and C-reactive protein, which is an inflammatory risk factor for coronary heart disease. And certain progesterones show some of estrogen's benefits. Estrogen therapy has also some associated risks, like risk for breast cancer and risk of heart disease, stroke. For progesterone therapy, duration of therapy is limited by the increased risk of breast cancer. For estrogen only, no sign of an increased risk of breast cancer was seen during an average of 7 years of treatment. Cessation of hormone replacement therapy. Abrupt withdrawal increases return of moderate to severe symptoms. Therefore, tapering doses decreases the risk of recurrence. A slow tapering is even better. So remember to do a tapering, because abrupt withdrawal causes an increased return of moderate to severe symptoms. Weaning should be performed in either of the following ways. We can decrease to lowest dose first, can decrease by one pill per week, we can skip 1 day, then 2 days, etc. Endometrial protection during hormone replacement therapy. So how can we protect endometrium during this therapy? We can give a daily progesterone for 10-14 days every month. Cycles should be performed 3-6 months, even though here is still insufficient evidence regarding endometrial safety. Keep in mind that progesterone is a large molecule, therefore absorption is not optimal through the skin. Then we can have Tibolone therapy, which is an alternative to hormone replacement therapy that does not require endometrial protection. It improves libido, but is less effective than conventional hormone replacement therapy in reducing hot flashes. Also, it should not be administered to breast cancer survivors because not considered safe. It's called STERs, selective tissue estrogenic activity regulators. So they have estrogenic, androgenic, and progestinic properties. So this Tibolone therapy is an alternative to hormone replacement therapy. Anyway, it's less effective than conventional HRT in reducing hot flashes. Other possible therapies are lifestyle modifications, so keeping cool core temperature, regular exercise, diet, weight loss, stop smoking, cultivate interpersonal relationships, stress relief management, and relaxation therapy. Isoflavone supplements, soy, red clover and black cohosh, and acupuncture. Treatment for vasomotor symptoms is SSRIs, SNRIs, and gabapentin. Vulvovaginal atrophy. Loss of adequate estrogen levels cause atrophy of the vaginal tissue. The following may occur. Labia and vulva lose fullness. Vagina loses collagen, adipose tissue, and ability to retain water. Blood vessels narrow and secretions from sebaceous glands decrease. Vaginal opening may narrow. Vaginal length may shorten. Surface epithelium loses outer fibrous layer. Decreases ratio of superficial to parabasal cells. All of this is related to the effect of estrogen on vaginal tissue. It maintains collagen content, therefore has an effect on thickness and elasticity. It maintains adequate levels of mucopolysaccharides and hyaluronic acid, keeping epithelial surfaces moist. It maintains optimal blood flow. It keeps epithelium rich in glycogen. And glycogen is a substrate for lactobacilli, which convert glucose to lactic acid, creating acidic pH. And acidic environment protects against vaginal and urinary tract infections. So, which are the effects of estrogen on the vaginal tissue? Are maintain collagen content, maintain adequate levels of mucopolysaccharide and hyaluronic acid, maintain optimal blood flow, keep epithelium rich in glycogen. Also, there is generally loss of glycogen that causes a consequent increase in pH more than 5. As said, this leads to formation of unfavorable environment for lactobacilli, but a more favorable susceptible one for pathogens for the skin and rectum, which can favor the development of urogenital problems like UTIs, dysuria, urgency, a bacterial urethritis, and urethral caruncles. Therefore, in the case of vulvovaginal atrophy, patients generally complain of vaginal dryness and itching, as said, discharge, which is yellow and malodorous, dyspareunia, which is painful intercourse, vaginal bleeding or spotting, and symptoms do not improve with time, unlike flushes. Who is the epidemiology of vulvovaginal atrophy? It affects 40% of postmenopausal women. 25% of gynecological consultations after menopause are due to this. The main symptom is vaginal dryness, found in 75% of cases. Iatrogenic menopause causes indeed vulvovaginal atrophy, also in young women. Bring one of the last, the treatment. How can you treat it? We have estrogen replacement. Both systemic and local treatments are effective. Generally, there is greater compliance to local treatments that require lower doses that do not lead to high systemic serum levels, and those the possible side effects associated. This is due to the wrong common knowledge and mediatic information which scare women. We can also use cream, rings, tablets are all similarly effective. We can also use fractional CO2 laser treatment. How does it work? This technique causes remodeling of the tissue with impressive results on vulvovaginal atrophy, as we see here. Impressive results indeed.